All right, two things. Sandy will tell you guys this. I'm very casual, so two things. One, call me Gillian. Two, please feel free to interrupt me at any point in time. If you guys have any questions or you want to make a comment or anything like that, we can be kind of casual with today, especially since it's a nice small group. This is a smaller group than fellows than usual. I was just saying to Anna Lynn, you must be extra special because I know a lot of people apply for these slots, so good job getting, one of the 7 of them. Okay, so you already got a little bit of background on me. Yep, I've been here now 6 years, so I'm now officially an associate professor. If you know about academia, that means something to you. If you don't, that's fine too. I also recently have become the director of technology research at the new Autism Center. A lot of my work is related to autism. The stuff that Sandy's doing this summer is related to autism, and I'll talk about that a little bit. And yeah, if you can't tell already, and you will be able to tell by in an hour, I do lots of collaborative work in health and education, and particularly around working with kids and so on. I'm not on Facebook, so if you find someone named Gillian Hayes on Facebook, she's probably a realtor from Scotland. Yes, that's a real person. But if I were on Facebook, the things you would know about me is I have a toddler, and I'm going to have another one soon. I have a husband, I have a dog who blogs, and I'm a huge Georgia football fan. Again, you're all West Coasters, you don't care, but this matters a lot if you're from the East Coast. Okay, so I'm going to do a little bit of a whirlwind today. That's why I said please interrupt me at any point if you guys you get lost or you just want to talk about something more, and we'll just readjust the schedule so that we can talk about what you want to talk about more. But I sort of want to talk about overall what does it mean to be in a technical field and do research for and with vulnerable populations, and what do we mean by vulnerable. I'll give you some example research projects, including Sandy's, and I'll do my best not to scoop her. And then I want to talk a little bit about the process of engaged research. And so what does it actually mean to do this community-based research? For those of you who might want to, if you're not already doing it, go out and work with the community and do this kind of work in the future. Okay, so first of all, what do you guys think I mean by vulnerable populations when I talk about that they have these higher risks? Who do you think it counts as like a vulnerable population? Any thoughts? Yes, Sandy, you can answer.
People with disadvantages.
Sure. So what makes them vulnerable? What kinds of things? Do you have some specific ideas in mind?
Disabilities.
Yeah, so you might have a disability. You might be low income, be at a high risk for other kinds of issues. These are the kinds of folks that we're talking about when we talk about vulnerable populations. So you probably hear that term used the most by, you guys are in college. Do you ever watch the news? Raise your hand if you actually watch the news. A couple people? You watch news other than Daily Show? Okay. It's all right. The entire world, there could have been a nuclear war when I was in college and I wouldn't have known. It's completely fine. It's expected. But you'll hear this term used a lot for the folks that are sort of in the social safety net. So these are people who maybe, are just on the edge of all kinds of other issues. And they're at much higher risk for a whole bunch of sort of social, mental, physical ailments, right, as part of being in this population. But they have really limited access to and experience with technologies, right? So we have this challenge where we think the technologies can do a lot of good in terms of promoting health and well-being, in terms of improving education, but you've got a group of people who most need it, who have the most trouble getting access to these things. So we have an opportunity then to say, okay, well, let's look at what we have now. We have these low-cost, high-powered mobile devices that we've never had before, that we can actually reach out to people. Things are becoming more prevalent, so there's a huge opportunity to actually reach these populations that haven't really been reachable in the past. Okay, here's the sciencey part. The big research challenges that I work on in this space, and there's lots more than these, but these are 4 that I really work on, is, as Anna Lynn said, I really look at improving record keeping and information access and comprehension. So how do we get people to actually document what's going on with their lives, and even more importantly, understand them, understand the records, be able to act on them, and so on. Then we need to support the lifetime of the data, right? Think about this for a minute. You're collecting all kinds of data all the time, whether it's your email, your Facebook, or specific like health apps that you might be using. If any of you are using like a Nike Fit and you're running, you're keeping logs of where you go all the time. And this data may exist long after you're gone. And especially when we look at little kids, we're thinking about like a person who is really evolving a lot over the next 60, 70, 80 years. And then after they're gone, that also exists. We have to think about data in those sort of long temporal spans. We have to ease the extensive burden on people. So has any of you ever had your doctor ask you to take a note on like every time you feel a symptom? No, you're all healthy and young. You haven't had these things yet. So it's a very common thing. When doctors are like, I don't know what's wrong with you. Just like carry a notebook around and every time you feel dizzy or whatever the symptom might be, write down what you were doing, right? That's a very common response. It's a really burdensome thing, particularly for someone who has a disability, has maybe 3 jobs, 2 kids, and a bunch of other things they're trying to deal with. And then of course we need to balance a bunch of concerns, right? So you think about data management, particularly health and education data, you think about who controls it. Who's managing these digital identities? What are the reputations of the people involved when we start to collect these data? What does it mean to know that you've got a bunch of mental health data on someone or you've got a bunch of HIV-related data on someone, and then that can affect their reputation and other things, their privacy. And this is particularly, go back to the vulnerable populations issue, this is a group of people who usually don't have much of a voice in terms of design and policy. And so how do we actually balance the concerns of those folks? Okay. So that's the sciencey part. Here's the pragmatic part. I like to put things out in the world. I like to actually make things and have them used by people. But the truth is that if you make a feasible solution to a real world problem, it's really, really messy, right? So this means that we don't get to sit around in the lab and think like, well, we have this really nice theory of behavior change and we're going to implement it in some technology and it's just going to work. We actually have to go out and talk to people and engage with them in depth in these really long-term, intense, messy engagements. And so Sandy's gotten a little hint of that this summer of, actually having to find teachers, find clinicians, these folks that we're going to talk to about things. And sometimes those work on our timeline and sometimes they don't. We have to go back later and talk to them more, and so on. So what does that actually mean in practice? It means that we do a lot of cross-disciplinary partnerships, including with people who are not researchers, right? So I regularly have school teachers, clinicians, occupational therapists, speech and language pathologists, all these folks who are not really researchers. They don't care about the research questions. They care about helping whoever they're trying to help at that moment. And I have to get them to engage in a research project with me. And that means that we have to respect a lot of other people's values and goals. So it's not just about answering my research questions and fulfilling the requirements of my grant. And it's not just about Sandy meeting the needs of her SURFIT project, but it's about also thinking about what do they want out of this relationship. And so what are they getting in return? And we can't just hand them sort of, crappy technology that might help us answer a research question. We have to hand them something they actually want. Okay. So what does this mean we do? This pretty cyclical. We try to study the needs of whatever population we're working with, sometimes over several years, sometimes over a shorter period, create novel technologies to support their needs, and then sort of deploy, evaluate, and iterate on these solutions. This is not unlike what happens in commercial production, but it's just got a little bit of a research bend on it. Okay. Now, because I'm a teacher at heart, I have to tell you, here's some stuff you should go and read in all of your spare time. And I'm going to tell you a little bit about, have you guys ever heard of pragmatism? Anyone? No history of science students in this room? Okay, so if any of you ever take a history of science class, you will hear about pragmatism. This is a movement that basically came about to say, so it used to be the case, you guys have heard the term ivory tower, yes? Sort of it's not very nice thing to say about academics, that they're sitting around in their ivory tower, up on high, thinking about the world, not actually engaging with it. Pragmatists came along and said, science is available to everyone. Everyone thinks scientifically, and that we are always asking questions about the world, and we are always trying to answer them, and that's what science is about. And so if science is available to everyone, but yet we know it's complex, we know it's all of these other things, what do we actually do with that? And then falling out of the pragmatists came along an even more sort of extreme idea, which is this idea of action research, where we say, okay, we're going to actually develop interventions with people who are not scientists, but we're going to do science by developing the interventions, testing them out, and seeing what happens. And Kurt Lewin, who's sort of credited with creating action research, said, the best way to try to understand something is to try to change it. And if you've ever tried to change anything, you can see that this becomes really clear. All these ideas you might have had about how something works in the first place, as soon as you start to tweak it, then you find out how it really works. And that's even true in code. I've seen lots of people try to tweak other people's code, and you learn a lot how that code was working in the first place. So this means that the action, so whatever intervention you're doing, in our case this is usually building a piece of technology and handing it to people, that's our means for developing knowledge. So it's not just that we go out and we do surveys and we try to collect empirical data or we talk to people. Those are all things we also do. But the action itself, we're sitting there, we're poking something, that's a way that we develop scientific knowledge. And we say, well, okay, then influence by research is an inevitable part of what's going on. It's not a bias, it's not a contaminant, it's something that's inevitable that we have to think about when we go into these situations, we're changing things. That's part of the scientific process. And ultimately, the local contexts and the local solutions are the most important thing. So making the people happy and making it work in the environment you're in is the most important thing that you're going to do. And that gets us back to really respecting what our community partners are doing. Okay, so, and the other thing I'll tell you about this, you can sort of sum this all up by, I always tell people technology is not what I do, it's how I do what I do. So technology for me is a tool by which we can find out things about other people. Okay, so I promised to give you examples complete with pretty pictures and all that good stuff. It's good for the video. Okay, so we're going to talk a little bit about pediatric health and education, and these are 3 separate projects here, although I'm not going to talk about all 3 of these. Basically, we figured out, okay, if we can improve data collection and we can improve analysis, particularly for very young kids, you can improve outcomes. This makes sense logically, right? Yes, I assume? Okay. And you see lots of problems with errors in records. So you make the wrong conclusion, you give the wrong drug, you give the wrong behavioral therapy, whatever, because you don't have very good records. So mobile computing, can remove some of the burden that caregivers are experiencing in terms of actually trying to document these things. They can enable things like analysis of caregiver and child data together, which is really, really hard when you're doing sort of paper-based, old-fashioned documentation. And lots of our projects have looked at how we can improve both the quantity and quality of caregiver communication. Because particularly with kids, you might have a situation where you've got a couple of parents, a nanny, a grandparent, a cousin, and 2 teachers and 6 doctors who are all looking at this one child with asthma. And so how do they communicate? And it turns out we are not very good as humans at regular communication around health. We're really good at communicating through data. So actually sharing information as a means for communication. Okay. But I wanted to move a little bit beyond some of the record-keeping things and think about, okay, yes, we know that we can measure and monitor. And lots of the technologies that we've built over time have been really focused on measuring and monitoring things kids are doing. How can we actually enable sort of inclusion and empowerment? So it's not entirely about the watchful eye looking at these kids and seeing, how we can make them better and these kinds of things, but it's actually about how can we let the kids or even their parents be empowered to take on whatever these challenges are for themselves. So those are the technologies I'm going to give you some examples of today, because that's what we're working on at the moment. Okay. MoSoCo, this is the Mobile Social Compass, which I just have to tell you guys, it used to be called ISO, also problematic in its own way, but what was most fun about this is that Monica, the postdoc that was working on this project, is from Mexico, and hearing ISO in a Mexican accent is fantastic. It comes out as I suck every time, so she changed the name of it. At any rate, the social compass this is an example of us working with some other folks. So Louie Boyd, who is the autism coordinator for North Orange County. So she sees every kid with autism in sort of the northern half of this county, which is a lot of kids. She developed this curriculum, which you can actually now buy. She has a nice book out on social skills. And so the idea is that you use these different kinds of what she calls gears. These are visual aids to help kids learn different kinds of social skills. So the proximity compass, this is one of my favorites. This is a visual aid about how far away somebody should be. You guys have any close talkers in your lives? You know what I'm talking about? People that you're just like, really, this is my space, you need to move. This is something, a lot of kids with autism struggle with, is figuring out how far away. Or they're really far, and you're a good friend and you're supposed to be having a conversation, you need to come in a little closer. And so the social compass or the proximity compass tells you about, if you're a family member, you can be here. If you're a friend, maybe here, and sort of gives you a sense of this social space. And the whole idea of this, and these are some of the other kinds of things that they teach. The whole idea of the social compass is about, getting visual aids, practicing using those visual aids, and then going out and experiencing their social skills. It turns out when we went and we tried to really understand how the social compass was being used in practice, the social compass curriculum is great. The teachers do a really nice job of it. When you have a controlled situation in which you're role playing, the kids really respond well to this curriculum. But when they were having trouble is generalizing, going out into recess and being able to understand the curriculum and remember what's going on and not be sort of feeling ostracized at the lunch table or at recess and so on. So we worked really closely with Luann and some of the other folks in the school there to evaluate the impact of the curriculum, but also to design technology to support for it, technological support for it. And then we evaluated that. So I want to just show you a little bit what MoSoCo actually looks like in practice. Okay, so these are kids using the system, and you can see it was just an Android-based phone that they hang on their necks. And this is one scenario. So this is about making eye contact, which is challenging, right? So we're actually we tell the kids they need to make eye contact with another kid. We sense whether or not they're actually both looking in the same direction. We give them, visual responses back that says like good job, thumbs up, or thumbs down. Maybe you walked away from the interaction before you actually made eye contact. Those kinds of things.
So can you talk about how that works exactly? How does the technology work there?
It works with a lot of extra support. So this isn't quite ready for prime time, so to speak. We have to put a bunch of Wi-Fi access points in the area so we can do triangulation on where they are and also which direction they're looking. And we also use Bluetooth to figure out sort of how close are they looking at each other, and then we use computer vision to figure out various things like are they making eye contact or do we think they're making eye contact? It's a little rough. And then it's all in augmented reality. This is a little bit old, but it uses the old Android augmented reality toolkit on top so that you get things like where you look up and you see the other kid's face, and then you see your thumbs up go across the screen over. So we're using both cameras, both directions. Does that make sense?
They're trying to get a thumbs up when they look at each other?
Right there, that's what they're doing, yeah. They also do other things. So that's just the eye contact's the very initial thing. So they also do a whole conversation turn, which I can actually walk you guys through right now. Okay, so this one, it tells her first, go look for this kid. It's giving her a suggestion of a conversation partner. There's also some other information in the back end there, like your different preferences, what kinds of games you like to play and things like that, and who's engaged in a conversation currently and who isn't. So the system will look for another kid who's not engaged currently who has similar interests to you, and will suggest somebody that you should go and talk to. One of the challenges is just in initiating the contact in the first place. So that's why this is the first step, that we tell them to go look for this student, and then they get told to make eye contact. Once they've made eye contact, they self-rate whether or not they think they get a thumbs up or a thumbs down as well. So because part of the curriculum is about learning, we all know that we have social interactions that don't go well, and that's okay, but you need to be able to identify that you didn't do well. And if they self-rate and the other student self-rates, and they rate each other the same and the system also thinks it's the same, then they'll get a star for that. So even if it was a negative interaction, if everybody agrees it was a negative interaction, they still get rewarded for that because that's part of the process of them learning. Sorry, I thought I had more images for you. I lied. And then these give you some of the other things. So this is like the proximity one, eye contact, proximity. Sadly, I can't remember what all these icons stand for. But at any rate, their devices, while they're in an interaction, are synced up with each other, and then we can have other devices that are synced with each other at the same time. You can only be synced with 2 people in the current prototype. There's loads of limitations with this project, I'll just tell you now. That's one of them. And then once they've finished the interaction and everybody sort of agrees that the interaction is over, then both their devices are sort of released from each other and they go and they sync with another one. They're always immediately prompted to go and find a different interaction partner. One of the goals of the therapy is that you interact with lots of people. one of the downsides that we did see in the deployment is that means that sometimes you get really into a conversation with one kid, and that's actually something that we would want to encourage, and they don't get to stay. Like, they've done a certain number of rounds, and that's a good enough conversation, and so we say, okay, go off and do your own thing and go be with someone else. So that's a little bit of a problem that needs to be sorted out. But figuring out how to end a conversation is actually really hard from a sort of machine learning standpoint. Okay, so we did deploy this. And what we see here are that social missteps were dramatically reduced when the kids were using the technology. And the deployment was in a social skills class, which has 9 neurotypical students and 3 students with autism. And that's they're purposely built that way so the kids with autism get more experience interacting with the neurotypical kids. So this is looking across everyone. The neurotypical kids also reduced their social missteps, so they would actually learn about eye contact and the appropriate proximity and so on. And these are like 4th and 5th graders, so we expect them to have decent social skills, but they're a little bit limited as well. I mean, 4th graders, if you know any of them, they do some odd social things from time to time. They had way fewer behavioral issues, so a really common problem with the kids with autism in this age range, right? They're rocking, they're jumping, they're making noises, and these are fairly high-functioning kids who are verbal and in a social skills class, but they're still doing these sort of what you might think of as typically autistic kinds of behaviors. We don't even really know how to run the stats on this because if you look across all the kids, we saw 50 of these kinds of incidents when they're not using the tool, and when they were using it, it went down to 1, which is just kind of a weird thing, and we can't sort of look at it from day to day. Okay. And then we see way more interactions, right? So I explained a little bit, we're prompting them to do those interactions, right? So this is expected and hoped for. But what was more interesting to me than the fact that we just had quantitatively more interactions, which we very much expected, was the strategies that we started to see. So we videotaped them at recess every day. And we started to see things like the kids started to learn about new interactions, and they would try to join groups in ways that they had not done previously. And they started to understand how groups are created. So they would talk to us in their interviews about, like, oh, I get it, there's a leader. And you have to kind of get the leader's attention, and then you're allowed to be in part of the group, right? And it's actually a pretty smart, perceptive thing to think about when you watch kids on the playground. I suspect most 4th graders don't have that level of understanding about the way in which these groups are formed. And then we also saw the neurotypical students start to adopt this kind of mentoring behavior. So even after we pulled the tool out, they would make sure that the kids with autism were playing and that they had much more integrated play than they had had prior to using the tool. This was really positive overall. What was most unexpected is that the sort of regular education students, they also learned a lot from this, and they would talk also about understanding the strategies much more. And so what we saw was that the schools then said, well, we want to use this with all our kids, like as an intervention the first couple of weeks when school lets in, or even like when they come back from a break, because you get all these little clicks and you have all these problems, and so we think this could really break those apart. We agree that it could, but it's really challenging for us because with your very perceptive question about how does this actually work, this technology is like, it takes an army to get the system to actually work. We have 3 people there all like doing stuff in the background for 15 minutes of recess every day. And so one of the big challenges with working with community partners like this is this issue of the schools want to use things that are not really hardened and not really ready to be used. And we had an interesting situation too where one of our primary contacts at the school had decided that she's going to leave her job, work on this, create a startup to create it, right? So there's a lot of kind of crazy, unexpected things that happen out of these kind of community partnerships. Okay, I'm going to switch gears a little bit to babies, because I like gratuitous pictures of my child in presentations. Preterm births. My child was not a preterm birth. My child was a week late and really didn't want to come out. But lots of them are. And what's happening now is, we've got sort of 1 in 10 kids in this country are born preterm. Why is this happening? One, advances in perinatal care, so basically what happens right after you're born, are much better. I mean, you've now got kids that are 22 weeks gestational age, which is barely over halfway there, living through a delivery, which is remarkable. And if you ever want to see just crazy science, go look at the neonatal intensive care unit at CHOC. But it's great that they're surviving. What's problematic is that these low birth weight children have really significantly high rates of limitations later on in life. So if you look at them when they're 6, 8, 10 years old, there's all kinds of problems. Anything from like asthma to cerebral palsy to other kinds of disabilities. So there's a lot of interest in improving the health of these infants. This one's also not mine, but it's so cute. Weight gain is the sort of critical determinant that allows you to be released from the hospital and that they think reduces the amount of problems you're going to have later in life. And so a bunch of really great UCI researchers who are not me have been doing this assisted exercise in the neonatal intensive care unit with these babies. So you can see the nurse doing that there. I mean, it's hilarious. They actually sit there and like work out the baby's little arms and stuff. And this is all built on the basic underlying theory, at least to my non-medical mind, is that all that kicking and moving around that goes on in the 3rd trimester is actually like pushing and building muscle. So it's a little baby, weight regimen. And so we need to replicate that on the outside as much as possible. Okay. That said, hospital stays are really costly. All right, if anyone's heard me talk before, you don't get to answer, but if you haven't heard me before, how much do you think the average NICU stay costs?
Per day.
By the time you check out?
10 grand.
10 grand? You have never been hospitalized, have you? 10 grand's like less than what it cost, I think, to have my child. All right, I've given you a massive hint by teasing him a bit. Anybody have another idea? Come on.
500?
You're getting close.
800K.
They can go as high as that, right? I mean, it's very common to be 300-400 grand all the way up to $1 million for some of the more severe cases. Yeah, really expensive. So there's a lot of interest in getting parents to do these kinds of exercises at home and other kinds of things, right? Not just the assistive exercise. That's sort of the initial motivation for what got us into this project, but all kinds of other things that we want parents to be able to do at home so you can get these babies out of the hospital as fast as possible. Huge challenge in sort of monitoring and supporting them at a distance, however. So this is Estrella. I'm not going to walk you through the whole details of it, but basically Android application that asks parents to track a whole bunch of stuff about themselves and their infants. So they track their diapers, they track the weight of their baby, they track their baby's mood as well as their own moods, and they get messages from a virtual coach, which is all technology giving them messages based on the data they're inputting, as well as they can get messages from the clinicians themselves in that same sort of inbox. On the other end, clinicians see something that look like this, right? So they get a dashboard that shows them what's going on with the diapers. This is, yes, we actually do vision algorithms on the diapers because the color of poop in an infant's really, really important, and is probably the #1 thing that pediatricians get called about. I have to say, the first time I saw that black stuff that comes out the first few days of your baby, I was terrified. Totally normal, right? But this is a really common thing that happens. And then we're looking at sort of charting when are their upcoming appointments, what's going on there. And then this is just another view of that dashboard, so they can see these are bonding activities that the parents were meant to be doing with the child, so they can see if the parents are doing them at a quick glance. Okay, so we were working with a bunch of clinicians from CHOC and UCI on this project for several years. And we developed these sort of shared research questions. And again, I just want to point out, some of these are good old-fashioned computer science kinds of questions, or at least informatics kinds of questions. Some of these are really medical questions. And this is, again, gets back to sort of why do we collaborate? We're looking at things like what issues impact adoption and use. That's a really common kind of question we would ask over in our department. But we're also looking at, how do we fit these into workflow for the clinicians who are very, very busy and don't have time to look at these data? What can we learn from the data themselves in terms of epidemiological kinds of information if we had this passed out across all the preterm babies in the world? Can we reduce no-show rates for appointments, which is a huge problem with this population? Those kinds of questions that are really more clinically oriented questions, but we incorporate into our research both because we're curious people and why not, but also because that's part of what it means to be in partnership. So we did a 4-month deployment study. There were 16 babies and 16 parents and 14 families. Why does that make sense? See if you're paying attention.
Multiple babies.
Yes, twins. Twins is a really common reason to be preterm, right? We excluded triplets and quadruplets because it's just too hard. It's hard technologically to figure out how to make an app that supports 4 babies simultaneously, and it's hard for parents. Parents logged data. They had the app for about 4 months. They logged the data for about 3/4 of the days in the study, so they had off days. They didn't want to log data. That's pretty common. Some of these things are not surprising. Data entry was easier if they used the study phone as their primary phone. We gave them full service on all the phones, so our lower income families actually did a little bit better because they typically didn't have a smartphone before. So they're like, sweet, smartphone. Whereas if we had somebody who already had their iPhone that they're totally addicted to, they're not switching over to our phone for the study, and so on. As their infants stabilize, they do get healthier in most cases. The motivation to track the data has sort of dropped, right? It's like, well, I'm not in crisis anymore. I'm not worried about my infant anymore. Things are okay. Parents using the phone were more likely to do their bonding activities than the ones who didn't have the phone. And they talked about being able to reflect on their own behaviors and on the correlation between their behaviors and their children's health. Okay, less enthusiastic results here. They only shared their data, however, in about 1/3 of their appointments with their clinicians. So they have all this data. They're going to see often 6, 7, 8 clinicians in a given month because their kid may have a GI problem and a respiratory problem and a whole bunch of other things. And most of the time, they're not sharing their data. Turns out, we have lots of really fun stories from the parents about like, well, the clinician kept asking me this question, that question, and I kept trying to show them the phone being like, here's the answer. And they were like, no, I don't need that. You tell me. And so that's something for us to look at in terms of clinical workflow. Like, what is it about that engagement and the way that MDs are trained that makes it really hard for them to engage with data in a different way? They would also forget the phone, or they just felt awkward. Like, well, it's really rushed, and they're coming in, and I don't know how to deal with that, so I don't show them anything. Okay. Parenting stress and engagement. So we knew before we got into this that parents who have preterm infants are way more stressed than parents with healthy infants. Mothers who come in with postpartum depression diagnoses way higher if you have a preterm. We gave them a postpartum depression scale as part of the study, so they would get it on their phone once a month. And almost 3/4 of them scored at risk for postpartum at least once during the study. This is even higher than the clinical data would indicate. We don't think that our population is more depressed. We think that we're catching it. So this is both scary from an overall thinking about postpartum depression standpoint, but it's also really exciting because it's an indicator to us that, we can help people to be more aware. We had at least one case where they actually went for a referral based on the data from the phone. And the clinical partners in another case actually intervened. So this mother kept getting a postpartum depression indicator and not calling to get a referral. And so one of our nurses actually called her up and they had a good conversation about it. So that was just a pilot study which led us to thinking about mental health in general. And realizing that, this thing that was really meant to be about babies was this strong indicator that we can do something about mental health, and mental health is really, really hard for lots of reasons. Anybody have any thoughts as to why mental health would be harder than, other kinds of like diabetes or something else that's physical?
Usually like a caregiver needs to report the data.
It might be the case you need a caregiver to report it because maybe your mental illness is making it impossible for you to see your own mental illness. That's a really common problem. Other thoughts?
It's pretty opinionated, right?
What do you mean opinionated?
Maybe like one person might think you have a mental problem, but someone else might not and thinks you're normal.
I think what you mean by that is subjective.
Yeah.
And yes, certainly, right? Like they're behavioral measures. So it's a little bit, you got to observe it, you got to talk to people. It's a little bit hard to know whether someone really needs help or not. Those are absolutely great examples. And there's also a lot of stigma around mental health. If I break my knee or something, you can't break your knee, can you? If I break my leg, right, then nobody's going to be like, oh, you're a bad person because you're walking around with a cast, right? But there's a lot of feelings of, if something's broken in your mental health. then you can be a bad person. Okay, so an example of one of our mental health applications is WellConnect. This is what Sandy's working on. You will hear more about it in a week. So I will do my best not to scoop her too much, but I do want to tell you a little bit about it. Okay. All right, how many of you are between the ages of 16 and 25? All right, most of you. You are at a very high risk for mental illness, suicide, alcoholism, drug abuse, and a whole bunch of other things. Sorry, it's just true. It turns out it's really hard to be you. I mean, it's extra hard. I always knew it was hard, but it's really, really hard. Transitioning out of your parents' home into an independent life, whether it's college or work or wherever, it's just really, really hard. And if you're from a low-income family, then you're particularly vulnerable to depression and a bunch of other negative consequences. And as if that's not bad enough, so you're more likely to get all of these things, and you're way less likely to get help for them. Right? So if I start to feel depressed or I develop a substance abuse problem, I'm much more likely to go and seek help than any of you are. And this happens for lots of reasons, right? It's hard. You're supposed to be young in the prime of your life. You don't want to accept necessarily that you're depressed. There's belief that medications are just not effective for depression. And then there's the embarrassment of your friends finding out, these kinds of things. You're a very peer-oriented group of people for the most part during this age of your life. But long-term consequences of this kind of depression are like poor overall functioning, lower self-esteem, lower performance in your school and your work, interpersonal and behavioral problems, you're breaking up with your boyfriends and girlfriends, you're warring with your roommates, all of these kinds of things, right? It's sort of a perfect storm of challenges in the 16 to 25-year-old population. And it turns out 16 to 25-year-olds are super hard to treat. You're sort of the least insured group of people anywhere. The story that you'll hear about that is that typically, people think that they're young and healthy and therefore don't need insurance. I don't know whether or not that's true or not. I think that may be a lot of politics around that, but you are a very uninsured group of people. If you're low income, again, you have additional problems. You might miss appointments because you need transportation to get to them. You have very poor adherence to medication, most likely. You forget or embarrass. These are sort of common things that everyone can do. Lower income people tend to have lower sort of medical literacy, health literacy, and so they may not understand why they need the medication. There's the stigma and then serious limited access to care. But there's huge growing smartphone use in the same population, right? So 67% of American young adults own a smartphone. That's a huge number when you consider that's all of the American young adults. So that includes people who are very low income. Most mobile phone users carry their phones with them at all times. How many of you have your phones on you right now? I did have mine on me. I just put it away because I didn't want it to buzz in the middle of the talk, right? But most of you are wearing them, or if it's not on you, it's like in your bag or somewhere close, right? So the idea was, okay, well, let's use smartphones then to improve self-care. And this is particularly useful for a young population who may move around a lot and other kinds of things that we see in the sort of low-income young adult population. And the original idea, and this was very much built on our work with clinical providers, was about appointment reminders, a medication log, we do some mood self-monitoring, have a validated depression survey, give some motivational messages. So you see here, like there's a weekly quote from Albert Einstein in there. And then they get points for using the app. And this is part of a mental health intervention that's going on in LA. And so the points actually get you can buy things in the store at the clinic. So it's a twofer, right? They get them into the clinic anyway, and then they also encourage them to use the app. I'm not going to walk through all the individual tiles. It probably looks a very familiar thing. This is basically a reskin of Estrella in terms of the initial prototype. Things that looked a little different in the Estrella moods, we used a different tool. Here, the clinicians really wanted 1 to 10 sort of numerical counts for how happy are you, how sad are you. You'd think these would correlate more closely than they do. Don't. How angry are you, those kinds of things. And then we can graph those out for people. Okay, so the current work is we're changing to a module-based system. So the idea being that, we started out with this very tightly tied to a clinical intervention that was happening in LA around urban youth, and depression. The more we talk to people about this, the more excited people get about using it for whatever population they're working with. So like student health here, for example, wants to make this available to everyone regardless, right? Because you may come in with no mental health challenges at all, but as we already saw, college is really hard, and this is a time you're really at a lot of risk. Likewise, we work with folks in an autism-focused transition program. So this is about kids who are high-functioning, we think can live independently, work independently, but they need to leave high school and their parents' care and go into these independent living situations. They're at lots of risk for mental health challenges and so on. So the idea is if we had a module-based system, we could pick and choose those little tiles that you saw, and maybe you get a medication one and maybe you don't, depending on what your needs are. Maybe you get a health and nutrition-related tile, maybe you don't. We can configure them both for specific populations and then also at the individual level. This has required engaging way more people. This is some of what Sandy's been doing with us this summer, is going like, okay, we already know what the depression psychiatrists say. We know what they say about this. Let's go and talk to the transition specialists. Let's go and talk to student health, these folks. And I'm not going to tell you any more about that because I think Sandy's going to tell you more next week, maybe. She's giving me a blank look. Okay, so with the last little, I have like, what, 10 minutes left? Yeah. I'll talk to you a little bit about the process of this with some colorful anecdotes where I hopefully will tell you all the things I did wrong so that you won't do them to you. So what does it mean to actually do this kind of engaged research, to work with the community and so on? Right? So I'm going to talk a little bit about all the way from developing the research questions all the way to sort of leaving the site, being done with it, and the ethical issues that come along the way. Okay. Community-based research is all about everything being shared, including the research questions. And this is a far departure from the way you sort of, if you think about the scientific method and sort of traditional science. So this is about saying, okay, we're going to develop shared research questions and we're going to have a shared problem statement amongst all of the partners who are involved in this. Okay, that's really scary and it's really hard to do. And the example that I'll give you, this is a picture from a computer clubhouse in Atlanta where I was doing research when I was a grad student. And we had tons and tons of theoretical and empirical data to back up what we thought were our research questions. And we were super excited to go into this site. And we're like, okay, we're going to go in and find out what the heck is wrong with these administrators and why aren't they doing the model the way that they're supposed to be doing the model. Like, this is a tested model across all of these computer clubhouses nationwide. There's tons of research that backs it up, and the Atlanta clubhouse is messing it all up. So we're going to go figure out like why the heck they're doing this and what's going on. As we did field work there and spent lots of time with these students, we started to learn really quickly that actually the model is deeply flawed. The model did not understand the particular needs of these students. They looked different in terms of demographics. They were having some different life experiences just based on where the clubhouse happened to be located. There was a bunch of things that were going on that were different. And so then we reformulated the question to be about, okay, how can we adapt the model to still work off the theoretical base that we believe drives a lot of change in these kids and drives a lot of interest in STEM learning, but also make it so it can be customized for individual sites, so that as we build out more and more of these clubhouses, you can actually make the model work and be flexible. So I give that example because it was one of my first awakening moments to like, hey, not everything that you read in a textbook is totally how it should work in the real world. Okay, the next step, once you figured out what the heck you're going to do, you got to figure out how you're going to do it. So you have this general idea, well, we want an app for mental health. Okay, that's a good general idea, but what are we going to actually do? And so thinking about the ways in which the technologies that we're designing and the organizations and the communities with which we're working are all sort of tied together, right? And you probably implicitly know that actually, because you've come up in a world in which you really get technology in a way that lots of other folks who are older than you don't. And we think about solutions being designed and implemented democratically and inclusively. So, this is about coming up with a design that meets the needs of the people you're working with, even if it's not the coolest thing you could do, even if it's not the thing that you think that you'd really like to try out, but it's something that you've worked together to figure out. And then we learn through the action. And ultimately, we say, well, whatever design that we're coming up with doesn't matter. It's all going to help us collect data. So it's all about, we're going to develop some knowledge based on this. This is like polar opposite of Apple's design strategy. And you know what? If you want to be a designer and that kind of designer, that's great, and you should do that. If you want to be a researcher, you have to do it this way. Okay, and then we have to evaluate it, right? So we've developed some intervention. We want to know, does it actually work? Why else are we doing it if we're not doing that? So one of the things that's really key here is that all evaluation is value laden. Don't let anyone tell you different. Every time you make a decision about what you're going to evaluate, how you're going to evaluate, what kind of data you're going to collect, and whose data matter, you're making value-based decisions. And so in community-based research, we very explicitly say, okay, if it's all value-laden, then we have to have a joint construction amongst everyone. We have to have all the stakeholders decide together what gets evaluated and seek ends that are acceptable to all these different stakeholders. I'm showing you these crazy graphs not only because lots of times evaluation looks like crazy graphs, but also because these graphs took me a week to make. And the reason is there is a very specific way that special education researchers make these graphs. And I won't bore you with the details, but let's just say Excel and I got friendly in a way that I really don't ever want to think about again. And no one on my dissertation committee cared. And no one that I was working with or would ever write me a letter of recommendation in the computer science world cared. But this one special educator that I was working with, this was really important to her. And so I gave up a week of my life to make these graphs look the way that she wanted them to. And that's a really important lesson for me and for all of you in thinking about the scope and thinking about the kinds of work that you do and making sure that everyone's needs are represented. Okay, documentation. You're sick of documentation, I'm sure, already, and you've only been doing research a short time, right? So you're nearing the end of the summer. You're probably all writing, I don't know, if you wrote code this summer, you're probably writing documents saying what the heck you wrote. You're creating presentations to give to various folks. You may be creating posters. Maybe if you're very lucky, you're submitting a research paper, right? These are all forms of documentation about the research process. It turns out in this kind of community-based research that we want to have that documentation include community partners. They're not going to read any of the things that I just said, right? For the most part, they want things in a different way. So this might mean creating non-academic work. This is not how I'm judged as an academic. I'm judged on how many journal articles that I produce, books, those kinds of things. But if a school board asks me to, I'm going to go and give a presentation to the school board. I might make them a video, might make them PowerPoint slides, whatever they want, right? Because this is about making sure that everyone is involved in the documentation process. At the same time, we try really hard to bring in our non-academic partners into writing the academic papers with us. This often means that we have to start earlier on writing those papers because it's a group of people who aren't really familiar with this. And we're all sort of working outside our comfort zone. Okay, slightly more fun. I totally recommend, if you're doing this kind of really long-term engagement with other folks, celebrate from time to time. So these are all pictures from work that I've done throughout the years. One is I was doing a long deployment in a school, and every month, at the end of the month, we'd have these various different milestones, about every month, maybe every 4 or 5 weeks. A different kid would get done with a portion of the study. And so we'd bring giant buckets of school supplies to the classroom so that all the kids, even the ones who weren't in the study, would get to come up and play with the school supplies, and everybody got to celebrate that something was happening. And that way, we weren't just there for 2 years trying to get data for 2 years. We're actually doing stuff on a regular basis. That's really fun. We had a party. The piece of software we were working on at the time was Caralog, so everybody who'd worked on the project got Team Caralog t-shirts. We barbecued regularly, do these kinds of things. So if you're working on a project over a really extended period of time, you don't just get burnt out and want to kill each other. And so these intermediate goals really need to be marked. That said, unfortunately, we do almost always end up leaving our projects in the end, right? And so you've developed these really long relationships with people, and then you move, you go get a job, you graduate, hopefully in all of your cases, right? The grant money runs out, and there's just nothing you can do. You can't engage any further. So one of the big goals here is about sustainable change. And I don't mean sustainable the way that Bill Tomlinson and other folks around here talk about it. I mean sustainable in terms of the change that you've made should exist long after the research team is gone. And that's part of why the community partners are so tightly involved all the time. This varies a lot from project to project. I will tell you it's much easier to make sustainable change in the healthcare industry because hospitals have IT directors than it is to do in schools, where they're really understaffed, and often they'll keep the computers around until they stop working, and then they kind of don't know what to do. But these are things that we try to think about a lot. Okay, and then the last thing, I've talked a lot about vulnerable populations. I've talked a lot about community partners, and these are groups that we need to have some special ethical considerations when we work with these folks. So we have the sort of standard research ethics that say things like, you can quit the study anytime, and you don't have to do things you don't want to, and we won't electro shock you. But you also have these additional things where we try to talk about sharing power amongst different people. I used to talk about this as making sure there was equal or even power, and after talking with lots of colleagues, I've thought about it some more and said, no, it's reciprocally uneven. There are things that I do really well, and there are things that the community partners do really well, and we each kind of have power in our domains, but we should have sort of equivalent amounts of it. This feeds into sort of considering what action are we going to undertake, because that in and of itself is a power move, and it's an ethical choice as to what you're going to do. Okay, so my closing thoughts are, positive community change is really central, but it goes alongside the research elements, so you can be both a do-gooder and a really good researcher. I swear, it's possible. But, these approaches do require these sort of long-term meaningful engagements with partners, and I really explicitly make a point to talk about folks as partners as opposed to subjects or participants. And that always remember that technology provides you a lot of options, which is awesome. You're all really good at it. But it's not a silver bullet, and you need to be mindful for when we can produce more challenges with it as well. Oh, and it helps bring women and minorities into computing, which is always a good thing. Okay, if you want to talk to me more, please don't hesitate to email. These are lots of nice people who paid for all this. If you want to look at publications or our research group, you can look up there. And I ran a little bit late, I'm sorry. So, anyway, I'm happy to answer additional questions either as a group or one-on-one as you guys want. But thanks for coming.